Good evening and welcome to Doctors on Call. I'm Dr. Mary Owen, Associate Dean of Native American Health and Director of the Center for American Indian and Minority Health at the University of Minnesota Medical School. I'm also a family physician for the Fond du Lac Band of Lake Superior, Chippewa. And I'm your host for our program tonight on heart problems and high blood pressure. The success of this program is very dependent on you, the viewers, so please call in your questions or email them to ask@pbsnorth.org. The telephone numbers can be found at the bottom of your screen. Our panelists this evening include Dr. Lief Christianson, a cardiologist with St. Luke's Cardiology Associates, Dr. Ryan Harden, a family medicine physician with the Gateway Family Health Clinic in Sandstone and faculty member at the Medical School, Duluth, and Dr. Jason Wall, a family medicine physician with the Duluth Family Medicine Residency Program. Our medical students answering the phones tonight are Regan Carlson from Sunburg, Minnesota, Riley Schmitter of Cedarburg, Wisconsin, and Micah Christensen from Alexandria, Minnesota. And now on to tonight's program on heart problems and high blood pressure. Welcome, you three. Thanks for being here this evening. We don't have questions from the audience yet, so we'll just start out with a few of our own questions that we frequently get as doctors in our clinics. A simple one, if you have high blood, Dr. Harden, we'll start with you. If you have high blood pressure, does that automatically mean that you have cardiovascular disease?
That's a great question. I spend a lot of time in my clinic managing high blood pressure. There's a lot of people around with high blood pressure. It's very common. It's asymptomatic. And if somebody has high blood pressure for a short period of time, it doesn't necessarily mean that they have heart disease. The reason that we want to identify, diagnose, and treat blood pressure ultimately is to prevent heart disease, which is the leading cause of death in North America. So it's high blood pressure is a major risk factor for the development of cardiovascular disease, but it's not everybody who has high blood pressure has heart disease.
Dr. Wall, what are other causes for cardiovascular disease or risk factors?
Certainly, in our working both in the clinic and the hospital, we see a lot of the behavioral, so the tobacco use and unfortunately with the opioid epidemic, a lot of injection substance use, and I see a lot of people with cardiac disease from infections of the heart from substance use, and of course, if you are tobacco use, it can cause all sorts of throughout the body, sort of the proverbial hardening of the arteries and vascular disease, and of course the blood vessels of the heart are not accepted from that. So.
And vascular disease is just disease of those same blood vessels that you're talking about.
Exactly. So, it's going to be kidneys, brain, vessels in the neck, and of course vessels in the heart as well.
And before we started the show, you mentioned another risk factor for heart disease, diabetes. Mm-hmm. So do you see a lot of that?
Certainly. Diabetes is, I'm very optimistic because technology is getting better and better for treating diabetes. We have better medications, and most importantly, we have much better ways. There's technology out there now where, 8 to 10 of your friends and family can monitor your blood sugars from their cell phones. So,
wow.
So that's great because not too many years ago, we didn't even know, if people weren't taking their blood sugars, we didn't know, it's dangerous if you're raising somebody's, insulin too high, because then they could become hypoglycemic, and that could be potentially fatal. So technology is helping us, but diabetes is a significant risk factor for contributing to vascular disease in the kidneys, in the eyes, and certainly in the heart too.
So it sounds like you're saying the way to not get cardiovascular disease then, the primary way is to control those risk factors. Not to feed you any information.
Correct.
Anything else to add to that, Dr. Christensen?
No, I think they touched upon that nicely. Other risk factors, at least modifiable risk factors, which are risk factors that you can do something about and control with medications, diet, exercise, things like that. Beyond diabetes, high blood pressure, smoking, things like that would be cholesterol, hyperlipidemia, and treating that. There's, of course, genetic factors as well. Your family history plays a big role in whether or not you develop cardiovascular disease or not. And there's not much you can do about that, unfortunately.
We talked about other forms of cardiovascular disease before we started the show. What do you think you see the most often in your clinic, in the cardiovascular clinic?
Well, I'm an interventional cardiologist, so kind of the plumber of the heart. So I treat a lot of heart attacks and things like that, and then structural disease like valvular disease and things like that. But we treat the gamut of things, so we see a lot of hypertension, high blood pressure in the clinic that we help manage, high cholesterol, things like that. And then of course there's all the other things in the realm of the heart, like atrial fibrillation, abnormal heart rhythms, things like that.
How are heart plumbers working these days? What do you do?
We're busy.
No, I mean, what do you do? What is
Well,
let's explain to the audience what that
So
means.
if somebody, for instance, comes in with complaints of what's called angina, so that's chest pain, that's heart chest pain, that's brought on by plaque in the vessels, that's gotten to a point that it's limiting blood flow. They might come in and say, I'm having these symptoms that are occurring with exertion, or they might feel short of breath. They might not have chest pain. And in that setting, we talk about what their symptoms look like, how they've progressed, and then we order up a variety of tests to help figure out, is this a heart problem or is it something else? And so some of those tests might include a stress test, an echocardiogram, which is an ultrasound of the heart. And moving on from there, then where it gets into kind of my realm, would be to do an angiogram, and that's a procedure where we put a catheter up to the heart arteries and we inject contrast into those vessels to see what they look like, and we're looking for blockage essentially, and then figure out if there's a problem there, if it's something that we can fix. So fixing an artery can be something called angioplasty, where we just use a balloon. That's not very common anymore. That's usually kind of a setup for the stent, which is like a little metal tube essentially that goes into the vessel. It smushes that plaque out of the way and helps open things up, and then hopefully those symptoms go away. The more dramatic end of this, of course, would be somebody who comes in with a heart attack, and we have to do that, kind of on a more emergent basis.
Okay, excellent. Thank you. That was helpful. We do have some questions from our folks out there. Heart palpitations. Dr. Wall, if someone is feeling heart palpitations, what kind of symptoms warrant a trip to the doctor? Also, I heard sometimes you can't feel heart palpitations. How do you know if you're having them?
Thanks, Doctor. Excellent question. The most common reason somebody's having palpitations is they're something that you would just notice and they're completely normal. We all have, and you really have to go a little deeper into what exactly you mean by palpitation, but kind of the pounding of the heart or a skipped beat are common ways that I think a palpitation is described to me. And so we have these premature atrial and ventricular, the way the heart beats, it'll skip a beat from time to time, and that's not a sign of anything pathologic or disease causing.
And you probably wouldn't feel that if it was 1 or 2 beats.
Yeah. When you couple that with the palpitations that don't go away, in a brief period of time, meaning, seconds to minutes, or if that's coupled with chest pain, shortness of breath, or if you're noticing it when you're just getting up, or if you're, whenever you move, I think that those would be cause for concern, and would certainly, any of us, I think, would want to look at an electrical tracing of the heart, an ECG or EKG, and probably look at the structure of the heart and any number of tests from, to make sure that there's not blood flow, structural problems with some lack of blood flow to the heart or a previous heart attack, any numbers. So an occasional skipped beat or a little pounding in the chest is probably just a normal variant, but if they persist or if they're coupled with any other, then they could be a sign of disease. And I, of course, defer to my colleagues here to embellish upon that, but yeah.
Yeah, I mean, they could really be just about anything. So it's kind of
different times in life you get them.
How long they last, how severe the symptoms are when they occur. Like you said, are there symptoms that are associated with it outside of just feeling like a skipped heartbeat? Are you feeling lightheaded, dizzy? Is there chest pain, shortness of breath? So the first thing is, how bothersome is it? Obviously, if somebody's not feeling well, if they feel like they're going to pass out or faint or things like that, or they're having a lot of symptoms with it, that's when you probably need to go into the hospital and get checked out. Outside of that, like you said, just do an ECG. We can do a heart monitor that they can wear as short as 1 day, 24 hours to help figure things out, or sometimes as long as 4 weeks.
Great.
And then that kind of helps figure out what the problem is it something to worry about or something that we just give reassurance for.
Great. Dr. Harden, we're hearing more and more different answers as to what a good blood pressure is. Patients are starting to hear that or have been hearing that. So can you tell us what a good blood pressure is? What do you aim for with your patients? And we'll see if everybody here disagree. I'm just kidding.
That's a great question. For the most part, a blood pressure less than 140/90 is ideal. Anything, if it's lower than that, it's actually a good thing. So even though if somebody has a blood pressure 140/90 or higher, we'll generally treat that with a medication. If somebody has a blood pressure of 120/80, that's better than 140/90. We wouldn't typically treat that with a medication though, because it's already relatively low. You can have a blood pressure that's too low. That's usually associated with a heart problem or a blood vessel problem or being over-medicated. Sometimes people are taking too many blood pressure medicines. There are some disease processes, typically diseases of the kidney, of the heart, like congestive heart failure, and diabetes, where because somebody already has a risk factor for heart disease in one of those other illnesses, we try to lower their blood pressure a little bit more. So for somebody with congestive heart failure, kidney problems, diabetes, we shoot for a little bit lower blood pressure, like 130 to 135/80 to 85. But for somebody with no other risk factors, under 140/90, that's what we're looking for.
Excellent, thanks. Anything to add to that? Anybody? Okay. How about you, Dr. Christianson? How often does vascular calcification that shows up in a monogram indicate cardiovascular disease?
A monogram?
That's what it has here. I thought it was the
maybe
calcification disease, but
I think if what we're talking about is like incidental finding of coronary calcification on an imaging study, whether it's like a CT scan or maybe they're saying mammogram, what it's a marker of is coronary artery disease or whatever vessel they're looking at. So if it got picked up in the neck, it's a mark. Calcium is a marker for atherosclerosis, plaque in the arteries, and typically. If there's calcium present, it's a marker of more mature plaque that's been around a little bit longer. So again, it might just be an incidental finding and nothing to worry about. We kind of always couple things that, the two most important things in medicine, we're deciding to, order another test or do something invasive is it going to make the patient live longer or is it going to make them feel better? If you can't answer those two questions, then you probably shouldn't be going any further. That being said, if something is incidentally found like that, you have to kind of go back to how we started this talk with managing risk factors, because again, it means that there is some degree of atherosclerosis. So managing blood pressure, managing high cholesterol, managing diabetes, tobacco cessation, all of those things. And depending on the severity of what this incidental finding was, it might be prudent to do more testing, but again, that's kind of uncertain. It's on a case-to-case basis, so to speak.
Okay, great. I see your colleagues here nodding, so we'll move on then. What causes heart failure, Dr. Wall?
Excellent question. Heart failure, there are 2 to 3, perhaps more, when you get into the details. Heart failure can be caused due to, first would be lack of blood flow to the heart. So when the heart can't get enough blood, it can't squeeze properly, and therefore there's this, blood goes into the heart squeezes, pumps it out, and when the heart can't squeeze properly, that is effectively a reduction in your cardiac output and heart failure. So ischemia, and then a stiff heart. So if your heart has been pumping because you've had years and years of high blood pressure, your heart can't relax very well, and so it can't fill very well. If your heart can't fill, then it can't pump the blood out, so that's another reduction of the cardiac output. Then there can be certain other forms that are associated with some rather rare diseases, but you can get some diseases of the heart where there's fluid and or tissue around the heart where it can't fully move within the pericardium, and that can cause restriction. But by and large, the most common are going to be the lack of the blood flow, and then damages from uncontrolled hypertension, or other heart failure can also happen, like rheumatic fever, which we see much less today. can damage one of the valves in the heart, and when the valves don't work properly, then it's hard to get the forward flow out of the heart. Unfortunately, we see that quite a bit now, at least in my practice, with injection substance use. The damaging bacteria from the skin can get into the heart and damage the valves, and fortunately we have good therapies to replace or repair those valves. As far as other forms of heart failure, I think there are a couple more, but they're not coming to me right now. And I mean, I think Dr. Christianson,
Go ahead.
I'll add to that congestive heart failure is actually a symptom of the heart. For some reason, the heart's not working right, like the reasons that Dr. Wall was mentioning. So somebody will come into the emergency room with the typical symptoms of heart failure: swollen legs, weight gain, short of breath, and they'll get admitted to the hospital to treat those symptoms. And then really the investigation begins. Right. What's causing this? And how do we treat it so they don't come back to the hospital with these symptoms again? So it's like you said, there's a lot of causes of heart failure, and sometimes it's hard to figure out what it is.
Mm-hmm. Sometimes it's, from you have chronic lung disease, and the lungs go through some changes to try to increase oxygenation, and so what that can do is when the blood vessels in the lungs constrict, it puts an incredible load on the heart too. So it's kind of this, when the lungs aren't working right, it puts strain on the heart, and that can cause the heart to fail as well, become too, even be an extreme athlete. If you train too long, some people get a hypertrophic, the muscles of the heart become too large. This is rare, but then once again you have a really muscular heart that doesn't relax well. That's our job when people come in is,
find out why.
Yep. Ultrasound, chest x-rays, lots of studies to help figure out the reason. And of course, doing an angiography, because that's one of the first things we look at. When somebody comes in with new onset heart failure, we have to prove to ourselves that there's not blocked vessels that we can reverse. And then if we reverse, then the cardiac function will get better.
Thank you. All right, we got lots of questions coming in from our interested audience, so we're going to start flying through some. Dr. Christianson, SVT, what does it mean, and what should patients be thinking about?
So SVT is short for supraventricular tachycardia. And really that's kind of an umbrella term for any abnormal heart rhythm that's coming from the top chambers of the heart. Specifically when we're talking about it, like if we're talking about it, we're usually kind of talking about a specific type of arrhythmia that's coming from the top, although again it really can be anything that's coming from the top chambers. So it's a rapid heart rate, usually starts very quickly, ends very quickly, so it'll be this kind of sudden on and then sudden off. Can have a variety of symptoms associated with it. The fortunate thing is that it can be treated easily, sometimes with just medications, but there's a procedure called an ablation that can be done, where they basically go in with a catheter and kind of zap this short circuit out. And that's 99% effective of getting rid of that abnormal heart rhythm forever.
Thank you.
A lot of heart rhythms are not that easy to treat, but that's a specific one that an ablation can wipe out.
Yep, good, thank you. Dr. Harden, this gentleman had a mitral valve replacement, was placed on metoprolol, and wants to know, is he going to have to be on metoprolol forever?
Probably. It depends on how that controls his heart rate, and if he ever has heart failure with that, that would definitely need to be monitored. Somebody who has a heart valve that's replaced is going to be monitored pretty frequently, at least initially by a cardiologist, and at least annually. And metoprolol is a medicine. One person might take 25 milligrams of it, one person might take 200 milligrams of it. Time will tell, has to be monitored. It depends, but he'll probably be on that medicine for good.
Okay. Patients are concerned about medications. So I have a patient here asking, I'm on atorvastatin, my lipids, my cholesterol has gone back to normal. Am I going to have to stay on atorvastatin? Dr. Wall.
Thank you for that question. Short answer is yes. And it's worth talking to your physician, because there are other statins out there. If you're having any side effects, it's worth trying. But yes, generally if you need a statin, it's a long-term medication.
Thank you for that. Going to get a tough one here.
Okay.
What effect does stress have on the heart?
Well, I mean, that's a hard one to answer, and I think it kind of depends on the level of stress.
Well, these days, with the news,
there is a link to, kind of high stress states and cardiovascular disease, heart attacks, things like that. There's also like a very specific type of kind of temporary, I'll say heart failure, heart condition, which is called broken heart syndrome. It has a lot of different names. Stress cardiomyopathy is another one, and Takotsubo syndrome. Takotsubo means octopus trap in Japanese. They were the first ones to describe this. And it's a condition where there's been a stressful situation. Yeah, it looks like an old school octopus trap, apparently, like climb into the sack and it would cinch up. And that's what the heart looks like, where only the base of the heart is kind of moving and the rest is just kind of hanging there like a sack. And this happens more commonly in women who have, it doesn't always have to be this way, but there's some sort of stressful situation has occurred, whether it's a death in the family or financial crisis, something like that, and it sets this off. So, that's kind of the more dramatic aspect of things, but stress does affect the heart.
Okay.
Yeah.
All right.
And I think this, there are these things called social determinants of health, and there was just a recent write-up, and I won't quote the exact journal we used to think that, there were a lot of looking at different like African American population, Caucasian population in the U.S. We used to think that just being a certain ethnicity or race raised your risk of heart disease, and so they looked at certain populations that conceivably had more stress due to financial violence in their neighborhoods, lack of park space, clean air, clean water, and they found that when they removed all those, they thought it was due to something genetic or ethnic or racial, and it was largely due to the stress. So unfortunately, stress,
particularly chronic stress,
is something that needs to be addressed as far as wellness in general, and particularly heart disease.
Thanks, Dr. Wall, for bringing that up.
If I could add to that too, a patient of mine actually about a year ago got me onto this. It was something that I probably never would have read or looked up. And he had gotten interested in looking into what's called ACEs, which I think stands for Adverse Childhood Events. And so traumatic events that happen in childhood lead to poorer outcomes in health later on in life, not just the heart, but other things as well. I thought that was fascinating.
This is what Dr. Harden and I teach all the time. Yep. And Dr. Wall, actually, with the residents. Yeah. Dr. Michael Marmot in England has done a lot of work on the effects of chronic stress on cardiovascular disease and chronic disease in general. So thank you for bringing it up. It's incredibly important. Could you explain, Dr. Harden, what AV node ablation is in 2 seconds?
Well, AV node ablation is if the AV node is like it's involved in making sure the heart beats at a specific rate. So AV node ablation is to interfere with the electrical pathways in the heart to regulate the rate better artificially.
Thank you. Dr. Christianson, could you discuss what pulse pressure is and if it might indicate heart problems?
Well, so that is sort of the difference between the systolic blood pressure and diastolic. I guess I don't have a quick answer for that one. That can mean a lot of different things if it's a wide pulse pressure, narrow pulse pressure, things like that. The short answer is yes, it might indicate problems.
Talk to your doctor.
Talk to your doctor, sure.
Thank you. This is a good question that we get fairly frequently. My mother passed away, and I'll ask you, Dr. Wall. My mother passed away at 83 years old, not this specific question, from cardiac tamponade. I'm a 70-year-old female. Should I have cardiac screening because of that? My mom had this disease.
Responding to that question, as far as I know, there's no way to screen for tamponade. Certain conditions can contribute to that, and so tamponade classically is there's a thick sac around the heart, and if there's fluid in that sac, that the heart cannot freely beat within that sac. And so that can happen after heart attacks, it can happen with cancer, it can happen with infection, and it can happen in certain instances of trauma.
No, I was just telling you we're getting short on time, but thank you. No, that was...
So I don't think that there's any, I don't think that caller should worry about it. I think it's just something to talk about at their visit with their doctor and find out exactly if she knows what happened to her mother, then it would be easier for us to risk stratify and say, this is something you should worry about, or that was completely independent.
Okay. Anything you want to add to that, Dr. Christianson?
No, I completely agree. I mean, I think it depends on what was the cause of the fluid accumulation around the heart that caused tamponade in her mother. Most of the times that's not going to be anything that's genetic. There might be some conditions, autoimmune diseases, things like that, that might be passed down. But that would be kind of a rare problem.
Well, audience, viewers, I'm so sorry. We have so many questions we weren't able to get to, but we had a fantastic conversation. I hope you'll join us again the next time we do cardiovascular disease, and thank you to our guests. I want to thank our panelists, Dr. Lief Christianson, Dr. Ryan Harden, and Dr. Jason Wall, and our medical student volunteers, Regan Carlson, Riley Schmitter, and Micah Christensen. Next week, please join Dr. Ray Christensen for a program on women's health and female cancers, when his panelists will be Dr. Michael Cassine, Dr. Sandy Stover, and Dr. Addie Vittorio. Thank you for watching, and good night.